Today, we will be discussing pathologic fractures of bone due to metastasis, one in the humerus and the other in the femur. Sit back and let's begin.
I think we'll do the usual. I'll show it on the screen and we'll go from here.
So what is this specimen?
Very nice. Keep the answers coming in. That's great. One last question. Can somebody in the chat let me know what bone do you think this is? Okay, great. We've got some answers in the chat that this is the humerus, and everyone is 100% correct. This is what we're going to call a segmental resection of the humerus. When we think about amputations, we're usually thinking about full limbs, usually transected across a bone. With a disarticulation specimen, we're also thinking more limb-like, but all taken off at a joint. An open biopsy typically refers to a smaller piece of tissue that's representative of the tumor being examined. So you're right, this is a piece of humerus. This is a segmental resection of this particular humerus. And just walking through the anatomy, you can see that the humeral head is here. It's nice and shiny. It's covered in cartilage. Anatomically speaking, the humeral head points medially. Up on the side here, you can see that the contour of the bone comes up a little bit. This is the greater tuberosity of the humerus, and that will be lateral on the specimen. By virtue of these two elements, we can see that this can either sit like this or like this. Okay. When we think about the anatomy of long bones, we generally have the epiphysis, which is the rounded portion covered in cartilage. And as you move into the shaft of the humerus, you get the diaphysis. Okay. Let's ask our next poll question. How many margins are there in this specimen? Okay, let's get back to this margin conversation. Technically looking at this specimen, there's truly only one margin, the distal bone margin. And that's here that I've taken off on the saw already. Given the nature of what we have, you can consider that there's actually some more soft tissue margins, but the surgical technique here didn't include a lot of soft tissue surrounding the specimen. But you can consider that there is an anterior soft tissue margin. There's a little bit of a medial soft tissue, posterior, and lateral as well. So you could, in theory, bump this up to 5 different margins. If we open this up, let's take a look at that, and let's get some descriptors or some gross words into the chat about what we're seeing here. Camera's struggling with us a little bit today, so forgive the focus here. Go ahead in the chat, just put down some descriptors of what you're seeing here, how you might approach the gross in this. Cystic, it's well-defined. Hemorrhagic, yep. Well demarcated, it's brown. Trabeculated, spongy, great.
Oh, that looks good. That should go through nicely on screen. Very spongy.
Soft to tan. Good. Any thoughts on what's happening here?
Yeah, and location too, right? That's also a good gross descriptor.
Great. Some really great answers. In terms of a gross for this particular specimen, the approach isn't too much different than any other gross description. We're going to measure the humerus in 3 dimensions. You can measure the diameter of the humeral head, measure the size of the distal margin. Going into the gross, we can talk about a lot of these different words: soft and cystic, hemorrhagic lesion. It's variegated, it's spongy, as we can see. Measure the lesion in 3 dimensions and its proximity to the distal bone margin. With any bone case, we always want to double check the clinical history and identify what is going on so we can approach the specimen accordingly. And also we want to be able to look at radiology, both in the clinical end before the patient went to surgery, and also with the specimen. So I'll just do a quick screen share here. So this is an X-ray of this particular humerus that I took yesterday before we cut it. And you can see, what are some of the interesting features you can see on this X-ray? You can throw that in the chat as well. Fracture, absolutely. You can see it cutting across the bone right in kind of that, the epiphysis there, or the metastasis. This cortical cloudiness, absolutely. Great, and so the purpose of the X-ray is to guide your dissection, how you want to approach the specimen. It also helps identify if there's any metal in the specimen, because depending on the type of resection, there may be a lot of different types of hardware attached to the specimen, which will make it a challenge to put through the saw for obvious reasons. And so having the X-ray, number one, allows you to see what's going on, but then also to guide your approach in terms of which plane of dissection you want to cut the bone in. Given what we saw here, we opted to cut this humerus coronally. And you can see the fracture here, it's really well preserved in the specimen and how it correlates to the radiologic findings of our specimen X-ray. Okay. With all of our bone specimens, we connect with our pathologist to do a review and kind of have a chat about what is appropriate for sectioning. This is particularly important for our sarcoma specimens. We usually cut this and block it out, have a conversation with our pathologist about what's appropriate. Given that this is a pathologic fracture, the sections that we take will be a little bit less than if this were a resection for a bone tumor.
By the way, we're not saying that this is sarcoma. I think all we can say is that this is a secondary bone lesion.
Okay, we're going to jump to our second specimen now.
Somewhat related. Oh, do you have an X-ray in the growth room?
Yeah, we'll get to that.
We've got a very keen audience. We always encourage this.
Okay, so what bone do we have here? Distal femur, because the other part I didn't show you, we have a portion of the tibial plateau here as well. Sorry about that. I'm just reading the screen as I'm talking. All right, let's go back here. So yes, this is a segmental resection of the distal femur. And how do we know that? Proximally, we know because you'd have a nice long diaphysis in the femoral head. As you come down, what happens is the femur widens, but we have the condyles of the femur. Okay, and these are the smooth cartilage-covered part of the distal femur, at the center of which is the intercondylar notch or the intercondylar fossa. The tibial plateau is much more flat. And this is just the top part of it resected here with the specimen. And together here, it articulates.
Very nice.
Yeah. Okay. So when we're looking at the femur in terms of orientation, we can see here we've got the condyles. And generally speaking, the lateral edge has a more gradual slope, and immediately it's a little bit steeper. Okay. So this is a segmental resection of the distal femur. Likewise, I want to share screen here again. So this is the X-ray of this specimen. And again, you can see some of these different changes related to what we're seeing on the specimen. To answer the question previously, do we have a faxitron? Fortunately, we do. We have a faxitron in our autopsy suite, and it's been a lifesaver in terms of getting radiology or radiographic images for a lot of our specimens, both our bony specimens, some of the composite resections we've seen in previous weeks, but it's also heavily used in our perinatal service as well. The patella was not resected in the specimen. So again, based on this X-ray, we opted to make the cut coronally, and I'll show you what that looks like now. Okay. So again, in the chat, let's throw in some descriptors of what you see here. And I do recognize the shine and the brightness of our room is making it a little bit harder to see, but let me see if I can just dab this.
So similar to the previous specimen, some gross descriptors, folks, in the chat.
It's solid, it's yellow. Great.
Again, think of location.
There's a fracture at the proximal end. Yeah, I
Good
like that.
pickup. Yeah,
Is that better?
I think it's the yellowness and the sheen
Yeah.
to it that's making
Yeah.
tracking difficult. Any other descriptors, folks?
It's multifocal. Oh,
Nice.
great. There's all some really great descriptors here for the lesion that you're seeing here. It is multifocal. We're seeing a little bit, there's one spot here. There's another spot here. There's this kind of soft tissue component here. There's some more through the middle. As somebody correctly pointed out, there is a fracture site. And again, there's this soft tissue component here as well that's a little bit calcified as well. Okay. In terms of a gross description, we're still looking at very similar approach. We're going to measure, document the fracture site, the involvement of this fracture site by some of this gray and white and some of these areas of softening. We'll talk about different foci of softening through the bone and in the adjacent soft tissue, and then also comment if any of the cortex of the bone has been breached or not. So what we'll generally do is we'll take a nice 5mm slice from here with the saw that we've got, and from there block out each section and then map it out onto a specimen map. So I think I'd like to throw up the next poll question, and this is just to get a sense of what is happening in the community with regards to your decalcification practices. What is your lab's preferred decalcifying solution? Is it EDTA, HCl, nitric acid, formic acid? No idea. If it's not represented, then you can also throw it in the chat as well. How many margins? Somebody's asking in this. We can think of it as one major margin, and that would be the proximal femoral margin. If we had a little bit more soft tissue, we could consider adding anterior, posterior, median, lateral to turn that into 5 as well.
Interesting.
That's great. So yeah, so EDTA is a decalcifying solution. It is a nice one because it's gentle on tissue, but it takes a long time. The HCl based is probably folks are using RDO perhaps as a commercial fixative. We use HCl in the context of Reichmann's solution, which is a blend of HCl and formic, both at 8%. Formic acid is also a nice one because it's a gentler decal fluid. That's great. And then how about we go to the next poll question?
So how does your site test for decalcification endpoint? Because again, it's important to not over decalcify, because you can imagine you're putting a live specimen in very strong organic acids, not the nicest conditions.
The manual method is tried and true. It may not be the most scientific, but it works. I'm curious to know, is this usually by just bending, or is it by poking with a scalpel or a probe of sorts?
Or the bounce method.
Probe or scalpel, great. Interesting to see that nobody's chosen the chemical method. For those of you that may not be aware, it's complex and labor intensive. You take your decal fluid, add hydroxide and ammonium oxalate into the solution. Calcium oxalate will precipitate out. If you keep getting this precipitate, it means there's still calcium to be leached out of the bone. Once you get a clear solution, you can say decal has reached its endpoint. Yes, we have a chemical method, but it is laborious. The challenge with this is, in theory, you should be doing one block at a time because you want to be able to optimize the decal period specific to the amount of calcium in each cassette. So you can imagine if you were decaling a number of different blocks, so this would be even more challenging than it already is. We use X-ray here. It's really great. Basically, we're looking at the bone in the cassette change from being radiolaopaque to radiolucent. And for the no idea folks, I encourage you to go talk to some of the histotechs involved or whoever's responsible for your decal and find out what your process is locally.
Okay, in the chat, we have 2 bone specimens here, but I'm curious, what other specimens should be decaled that comes through the lab? Everyone immediately thinks about bone. Yes, valves, excellent. Any other examples? Teeth, that's a good one. Bone marrow, thank you. Oh, dermoid's a good one, thank you. Yeah, Yeah, I think we got most of it. It's important to know that if there's calcium, it's not good for the cutters. Histology will be really mad at you if you put that through. So ideally, and then just with respect to decalcification, and last question about decal, I promise, which of the following medium can both fix and decalcify? This is important in terms of handling your specimen. If you've worked with marrows, you'd know the answer. Interesting. Okay. All right. We'll end there, I think. It's good spread overall. Share the results. And yeah, I think people got the two correct answers, which is Bowens and Zenkers. The hint there was for bone marrow specimens, these were traditionally used because of that double functionality of both being able to fix and decalcify at the same time. Formalin, again, mostly for just fixation. Alcohol, again, fixation. RPMI does nothing. It's just a buffered solution. RDO is that commercial version of hydrochloric acid. And Michelle is just, again, buffered saline solution, really, for transporting. Yeah, so Bowens and Zenkers. So just to drive home that point, I'm going to quickly share my screen and show people, again, remind people that there's many other specimens requiring decal that's not just bone. So some great examples there: bone marrow vessels with calcified plaques, and that also goes with, with valves, teratomas, of course, someone had mentioned, discs, right? Meningiomas, some meningiomas would require that, some ovarian tumors would that as well. Once in a while, you'll get epiploic appendages that are infarcted and calcified. Those can be quite calcified. With respect to those two solutions, just wanted to highlight the difference between the two and why they're kind of fallen out of favor for the most part. Bowens, I think we've had some discussions in previous times about its ability to explode. So just to be careful with that one. And Zenkers has mercury. So again, probably not the best thing to use. Regardless, both of them result in pure immunoreactivity. So for the most part, people have fallen out of favor for that one. I just wanted to bring it back to our samples here. We're not going to give you clinical information here outside of saying that these are secondary bone lesions, which is by far the most common bone lesion rather than the primary ones. And so I was going to ask this question regarding bony mets, which is not a common source in adults. Good response. Most people got the right answer here. Melanoma is not the most common. The first four actually makes up about 70% of all the bony mets in adults. In fact, two of these four are specimens for today. We're not going to say which one, and there's different characteristics either on X-ray or on gross that can help narrow it down, most notably being the prostate, which has, and someone in the chat put me, what's that type of bony findings associated with prostate mets? Yeah, sclerotic, blastic, that type of thing. Most are osteolytic. So we'll stop there. And I think with that, we will end our session for today. Nice, short and sweet session regarding bony mets. Again, if there's any questions, please let us know in the chat. Otherwise, it looks like it's going to be a beautiful weekend, folks. Enjoy. Thank you for coming.
Thanks, everyone. Have a great weekend.